Welcome to Deep Dive Ortho, the show dedicated to cutting through the noise and getting to the heart of what truly matters in healthcare. If you're navigating the demanding world of medicine, you know the relentless pace. It's a constant juggle, patient needs, clinical decisions, and then, well, there's the mountain of records and the need for seamless information exchange. It often feels like the administrative burden itself could be a full-time job, doesn't it? Today, we're plunging deep into that very challenge, the complex, often frustrating yet undeniably vital landscape of clinical documentation and communication. We'll be uncovering the core problems, exploring some A-Nor truly innovative solutions, and highlighting best practices that can genuinely transform how you work. And joining me to navigate this crucial terrain is an expert with expansive insight into this area. Welcome.
Thank you. It's a pleasure to be here. And you've really hit on the core tension, haven't you? Documentation and communication aren't just, bureaucratic hoops. They are absolutely the bedrock. They underpin patient care, continuity, operational efficiency, and of course, regulatory compliance. Hugely important. But we can't ignore the pressure this puts on clinicians. It often feels less like a helpful tool and more like, well, an added weight.
It absolutely does. So, our mission today is clear: cut through the overload and pinpoint essential insights. We want to empower you, our listener, to navigate these challenges more effectively, enhance your practice, and ultimately improve patient outcomes. Let's really get into this. Professor, let's start with that feeling of documentation overload. We've gone digital, yet it still feels like, well, a mountain. What does the evidence say about the true scale? Why is it still such a persistent issue?
It's definitely more than just a feeling. The data backs it up quite strongly. It paints a stark picture. Research indicates that for every single hour physicians spend in direct patient care, they often spend nearly 2 additional hours just on EHRs and related desk work.
2 additional hours for every 1 hour with the patient.
Exactly. Just pause and think about that ratio. Twice the time on admin compared to direct patient interaction. And this isn't just simple note-taking. It's incredibly detailed patient histories, extensive administrative reporting, compliance checklists that seem to grow every year. Each part might seem necessary, but the cumulative volume becomes overwhelming. It's genuinely unmanageable for many. A real factor in eroding job satisfaction, I think.
That sounds utterly exhausting, and certainly not why people go into medicine. What's the clinical impact of that relentless strain on staff and critically on patient safety?
The impact is profound and frankly quite severe. This strain directly fuels clinician burnout. It leads to reduced productivity during clinical hours, increased fatigue. When you're constantly battling a backlog or wrestling with a difficult system, it just saps your energy and focus. And this fatigue, it demonstrably elevates the likelihood of errors creeping into patient records.
And these aren't trivial errors, I imagine.
Not at all. We're talking about potentially serious consequences.
Sure.
Compromised patient safety due to inaccurate or missing information, delayed treatments because vital details are buried or missed, and even significant regulatory penalties for noncompliance, which then just adds another layer of stress. It's a detrimental cycle, really. It detracts from the quality of care.
So, if it's such a pervasive and critical issue, what are the most promising solutions? Is it purely about better tech, or do we need broader changes?
It absolutely demands a dual approach. We need smarter technology, yes, but deployed thoughtfully alongside strategic workflow improvements. On the tech side, the focus has to be on intelligent EHR systems. Systems with automation features that handle repetitive tasks, reducing that manual data entry burden. Think about EHRs that intelligently suggest codes or pre-populate fields based on context instead of requiring every detail entered from scratch. Customizable documentation templates are also incredibly powerful. They streamline common entries, ensure consistency without losing crucial detail.
But technology alone isn't the answer, you're saying?
No, definitely not. Alongside tech advancement, we critically need clear, concise documentation guidelines. Not just what to document, but how to do it efficiently and effectively. And perhaps most importantly, this needs rigorous ongoing staff training. It's not enough just to provide the tools. Clinicians need to be proficient in using them and understand the guidelines. That empowers them to use the tech effectively, freeing up their time and mental energy for what really matters: high-quality patient care.
That makes complete sense, empowering the user, not just digitizing the burden. Let's drill down into a related issue: the frustration with the EHR user experience itself. What's the fundamental problem there?
The core flaw, I think, lies in their original design philosophy. Too often, they were built prioritizing technical capabilities, data capture, almost designed by engineers for data, not by clinicians for workflow. They didn't prioritize the practical, day-to-day needs of the healthcare professionals using them constantly.
Which leads to the complaints we hear, the clunky interfaces, the clicks.
Exactly. Clunky interfaces, confusing navigation, an overwhelming number of clicks for simple tasks. It feels like the system actively hinders you rather than guiding you. It's not just an inconvenience. It erects real barriers to efficient work. It erodes trust in the very tools meant to help. A fundamental disconnect.
And the direct impact of that poor user experience on workflow, on well-being. I can imagine the frustration in a busy clinic.
Oh, the impact is profound. It directly breeds frustration. That frustration inflates documentation time, significantly turning a quick entry into a prolonged battle. This extra time and mental effort also dramatically increase the chance of errors. If systems are hard to navigate, clinicians might use workarounds, or worse.
Incomplete entries.
Exactly, or rushed entries just to get it done. This undermines the accuracy and reliability of the record, potentially jeopardizing care. Long-term, it's a major contributor to burnout, reduced job satisfaction, even higher staff turnover. It's a silent drain on the profession.
So how do we fix this? What does a truly user-centered solution look like for EHRs?
The key, unequivocally, is a pivot towards user-centered design principles. System development must start and end with understanding the real-world needs of frontline staff. We need intuitive interfaces layouts that make immediate sense, not steep learning curves. Logical workflows that mirror clinical thinking. Clear, unambiguous prompts.
Guiding the user effectively.
Precisely, guiding them without ambiguity or unnecessary steps. But design isn't a one-off thing. A vital component is establishing regular feedback loops with frontline staff. They know what works and what doesn't. Their insights are invaluable for pinpointing pain points, refining usability, ensuring EHRs become genuine enablers, not obstacles. It needs to be iterative, user-driven.
Let's broaden our scope beyond individual patient records. Let's look at communication between different parts of the system specifically, written communication between general practice and specialized care. What's the state of play there?
Where written communication, referral letters, discharge letters, it remains the absolute cornerstone of information exchange between primary and specialized care. Its quality is paramount for continuity. But what's fascinating and quite concerning is the consistent finding of significant perceptual discrepancies between GPs and specialists about the quality of this mutual communication.
Differing perceptions, that sounds problematic for care coordination.
It is indeed. It directly impacts how well care is coordinated.
Can you elaborate? What do specialists typically say about the communication they get from GPs?
From the specialist viewpoint, a recurring theme is that GP referral letters often lack sufficient crucial information. Studies show only about 29% of specialists rate GP referral letters as genuinely good quality. That's quite low.
Less than a third. Wow.
Yes. Beyond the letter content, specialists often worry that GPs don't sufficiently follow their advice once given, creating potential gaps in care. And a particular frustration is perceived poor telephone accessibility. Only about 33% of specialists find it easy to reach a GP by phone for urgent clarification. This lack of direct access can sometimes force specialists to make decisions with less complete information than they'd like.
And flipping that coin, how do GPs see it? Are their frustrations similar, or is it a different picture?
It's often a markedly different view. GPs frequently feel that the specific questions they pose in referral letters aren't adequately addressed or are even missed entirely in the specialist's reply. This leaves them uncertain when following up. Their perception of their own phone accessibility is much higher. Over 85% of GPs think it's good. A clear disconnect there.
A huge difference.
Massive. And GPs rate their own compliance with specialist advice much higher than specialists perceive it. Critically, less than a quarter of GPs feel specialist letters arrive promptly. These delays hinder their ability to act on recommendations quickly. So persistent gaps exist despite good intentions on both sides.
It certainly sounds like a communication breakdown. Are there concrete examples, hard data, highlighting these inefficiencies beyond perception?
Oh, absolutely. The data is quite alarming. One study found GP letters had inaccurate medication lists, wrong drugs or doses in a staggering 42% of cases.
42%. The potential for error there is huge.
Immense. Another significant study in Norway looked at referral and discharge letters. It found low consensus between primary and secondary care. And critically, a majority of referral letters were deemed low quality, so low they were considered a health hazard.
A health hazard? That's strong language.
It is, but it reflects the potential impact. The same study found 20% of discharge letters missed vital medical information, and less than half had high-quality info on activities of daily living, ADL, social networks, or home care needs all crucial for holistic follow-up. These aren't minor omissions, they directly impact safety and continuity.
That's incredibly concerning. So why this consistent pattern of poor content? Is it just lack of effort, or are there deeper issues?
It's definitely not lack of effort. The reasons are multifactorial. A huge factor is simply lack of time. Clinicians on both sides are under immense pressure. Quality documentation, while vital, often loses out to immediate patient contact due to time constraints.
The time pressure again.
Always. Secondly, there are often differing points of view. GPs and specialists approach problems differently, prioritize different information based on their roles. A specialist might focus intensely on a specific diagnosis, while the GP needs a broader view, overall health, social context, ability to manage at home. This leads to different ideas of what's essential.
And the purpose of the letters themselves.
That too. They might see the letter's goals differently. A GP sees a referral as crucial info transfer to start care. A specialist might also view their reply as an archiving tool. This can mean specialist letters become overly detailed, less useful for quick, actionable decisions by the GP. These unspoken differences contribute significantly to the gaps.
Given these inefficiencies, the content is crucial. Is there at least a consensus on what should be in these letters for effective communication?
Yes. Thankfully, there's remarkably strong consensus, backed by over 20 years of research. Both GPs and specialists largely agree on important items in referral letters. Things like a clear reason for referral, history problem outline, important medical history, examination findings, investigation results, current medication, socio-psychological factors, known allergies. Also, patient involvement in the decision, what the patient's relative has been told, their expectations, and crucially, what the referring doctor specifically expects from the specialist. So the ideal content is well defined.
That's a comprehensive list. Are there specific additions recommended for certain areas, like mental health care?
Absolutely. In mental health care, there's a stronger recommended emphasis. Beyond the standard items, referrals should highlight planned integrated care, clarify the specialist's specific role, and stress explicit patient involvement even more. It reflects the complex, often longitudinal nature of mental health conditions and the need for truly collaborative, patient-centered care.
And despite this consensus, what common items are still often missing, or what do specialists still feel they need more of?
Unfortunately, omissions persist. A very common issue is GP referrals lacking a specific, clear question for the specialist. Or if there is one, it's not always addressed in the reply. That hinders targeted exchange.
Leaving everyone in limbo.
Pretty much. Oncologists, for example, consistently want more comprehensive info on overall medical status, involvement of other doctors, and any special considerations impacting treatment. These aren't minor preferences, they're critical gaps.
So if the referral starts the process, the discharge letter is the critical endpoint for continuity. What do GPs rate as most important in that letter for follow-up?
For seamless follow-up, GPs consistently rate several items as paramount. The main diagnosis, obviously. Physical findings from the hospital stay, results of investigations. Critically, any test results still pending at discharge. The discharge medication list, with clear reasons for any changes vital to prevent errors. Details of follow-up arrangements, and information given to the patient and family. These are the essentials for the GP to confidently take over care.
It sounds like a lot of crucial information. But are there still challenges or common omissions in discharge letters hindering follow-up?
Yes, significant challenges persist. Studies have found instances of wrong diagnoses in discharge letters, obviously very serious. Discrepancies, too, up to 39% of discharge summaries differ from the actual take-home prescription, a major safety concern.
Almost 40%.
Indeed. Beyond accuracy, letters often aren't well tailored to the referrer's needs. They lack info on future tests, treatment options, side effects, prognosis. GPs then have to chase info or make decisions with an incomplete picture. And readability is a huge issue. Specialist letters are often too detailed, dense, poorly structured, no headings, long paragraphs, making it hard for a busy GP to quickly find the critical, actionable information. Lack of clarity can be as bad as missing content.
We've covered the documentation burden and communication inefficiencies. Now, the consequences. Beyond the impact on clinicians, what's a broader economic impact? It feels like a hidden cost, doesn't it?
It absolutely is a hidden cost, and surprisingly under-quantified, despite its huge influence on safety and operations. While providers spend so much time communicating, studies quantifying the precise economic impact of inefficiencies are scarce. Quite amazing, really, given how communication affects everything.
So, looking at what has been quantified, what sort of figures are we talking about for direct economic losses from these breakdowns?
The figures that are available are substantial, eye-opening, really. In U.S. hospitals, the estimated financial waste from communication inefficiencies exceeds $12.4 billion per year.
$12 billion. That's staggering.
It is. For a typical 500-bed hospital, that's about $4 million annually lost just due to these issues. And more than half of that, 53%, is attributed to increased patient length of stay. Poor communication means patients stay longer than medically needed, incurring avoidable costs.
And beyond longer stays, you mentioned wasted staff time.
Yes, a huge portion comes from wasted staff time. For nurses, it's estimated at $4.9 billion annually in wasted time due to communication inefficiencies. Studies show about 20% of a nursing shift is care coordination, intense communication, and another 6.6% is just wasted time due to breakdowns, duplication, searching for info.
Over 6% just wasted.
Yes. Similarly, wasted physician time in hospitals is estimated at $800 million annually. Communication can be up to 24% of a specialist's work time. When that's inefficient, the economic impact is immense.
So it's longer stays, wasted staff time. Are there other avoidable healthcare costs linked to poor communication?
Absolutely. The impact is broader. Avoidable hospital admissions and readmissions are significant. Research shows interventions to improve communication directly reduce these unnecessary stays, a clear link to cost savings. Poor communication also contributes to unnecessary testing, polypharmacy, inappropriate use of multiple meds, inappropriate referrals, or repeated referrals for problems not adequately addressed the first time due to unclear communication. All generate avoidable costs.
You've outlined a broad impact. Are there specific costs in particular areas, like cancer care?
Yes, in cancer care, three distinct, often overlooked costs arise from poor communication. Firstly, psychological distress for patients and families, which can lead to further healthcare needs. Secondly, unnecessary treatment. If information isn't clear or patient preferences aren't fully understood, interventions might not be optimal for that individual. And thirdly, indirect system distress the strain on healthcare providers themselves when communication constantly fails. This impacts their well-being and performance. These costs, though harder to quantify financially, are a significant burden.
Beyond economics, the ultimate concern is patient safety. What's the direct link between poor documentation and communication and compromised safety?
The link is critical and often direct and devastating. Medical residents on the front lines consistently identify communication difficulties as the cause of the vast majority of medical mishaps. It's not theoretical. A concrete example: 10% of test results post-discharge need GP action. If these don't reach the GP promptly or the communication is unclear, it can directly lead to preventable medical errors, potentially severe consequences.
That's a stark example. Are there broader studies quantifying how much communication problems contribute to adverse outcomes overall?
Yes. A notable Australian study found communication problems were directly responsible for 11% of all identified adverse outcomes.
11%. How does that compare to other factors?
Well, in the same study, inadequate practitioner skill accounted for 6% and inadequate resources for 4%. So communication failures were a leading contributor, exceeding factors we might instinctively focus on. It underscores how fundamental effective communication is to safety.
And how does patient satisfaction fit in, especially regarding malpractice claims? There feels like a link there.
An incredibly strong link, well documented. Higher patient satisfaction correlates strongly with positive communication behaviors, active listening, clear information, empathy. Conversely, studies show a clear link between poor patient-physician communication and higher rates of malpractice claims. One study found primary care physicians with no malpractice claims used more facilitation, encouraged dialogue, checked understanding, solicited opinions. Effective patient-centered communication seems to be a powerful mitigating factor against litigation.
So it's not just about avoiding negatives. Can effective communication actually lead to demonstrably improved health outcomes?
An excellent question, and the data is compelling. Even if direct causation is hard to isolate due to multiple influences, there are consistent positive associations between effective communication skills and tangible health improvements. Better physiological measures, blood pressure, glucose levels, improved health status, fewer headaches, less depression, better functional status, less patient distress.
So it genuinely makes a difference to health.
The evidence strongly suggests it does. When clinicians use best practice communication-specific, simple language, repetition, minimal jargon, checking understanding it influences patient health positively. It helps patients recall and understand information, leading to better adherence to therapy, all critical for optimal outcomes.
The challenges are clear, but so is the need to improve. Let's turn to solutions, specifically the potential of artificial intelligence, AI, in clinical documentation. How is AI starting to reshape this demanding area?
AI holds truly transformative potential here. Its promise is to automate many of the tedious, time-consuming tasks burdening clinicians. By offloading these administrative elements, AI can save invaluable time, allowing clinicians to refocus on direct patient interaction, shifting the paradigm towards being more patient-centric.
That sounds incredibly promising. What are some specific ways AI is being applied right now? Real-world examples.
Certainly, one exciting area is automated transcription and note-taking. Ambient AI voice recognition can convert clinician-patient conversations into structured medical notes in real time.
So the clinician can focus entirely on the patient.
Exactly. Maintain eye contact, pick up cues, while the AI captures the details, reducing that post-encounter admin drastically. Another area is EHR integration and data extraction. AI helps streamline entering, retrieving, and organizing clinical data within EHRs, making data flow more intelligently. We're also seeing contextual summarization. AI can quickly summarize lengthy documents or interactions into concise, meaningful notes, easy for others to digest or for quick review. And finally, clinical coding. AI can take on this time-consuming, error-prone task of assigning codes for billing and compliance, minimizing errors, and accelerating revenue cycles.
That's impressive. Is there actual evidence these AI tools are making a measurable difference, reducing burden, improving interactions?
Yes, very encouraging evidence is emerging.
Mhm.
A large study over 3,400 physicians, 300,000 encounters looked at ambient AI scribes. The results showed they demonstrably reduced documentation burdens. Physicians reported spending less time on admin and more time engaging meaningfully with patients.
And the quality of the AI notes.
Remarkably high, an average quality score of 48 out of 50. However, it's crucial to stress that physician oversight remains essential. AI is highly effective, but we need that human check for consistency, nuance, and absolute reliability. It's an assistant, not a replacement.
A powerful way to reclaim clinical time. Now let's pivot to secure digital communication. We hear about staff using consumer tools like WhatsApp for work. Why is this such a big problem?
It's a significant problem because consumer tools like WhatsApp fundamentally do not meet the rigorous security standards required for healthcare data. NHS trusts have been very clear on this. They offer convenience, yes, but their architecture and data handling pose serious, unacceptable risks to patient confidentiality. Relying on them puts sensitive data at risk, often due to a lack of suitable alternatives.
What are the legal implications under GDPR, for example, and what are the specific security flaws making them so problematic clinically?
Under GDPR, the implications are extremely serious. Breaches of data protection laws, patient privacy, leading to substantial fines and significant reputational damage. The specific flaws are numerous. Data often isn't stored on UK-based N3-approved servers, a key requirement. Data frequently isn't encrypted on the user's phone to healthcare standards. Often there's no PIN or login required for the app itself, meaning anyone with phone access could view sensitive data.
And things like photos.
Exactly. Patient images can get saved to the phone's native gallery mixed with personal photos. A huge risk if the phone is shared or cloud sync is on. Critically, even if one user turns off backups, you can't control if the recipient has. Data could end up on unauthorized cloud services, completely outside organizational control, unsuitable and dangerous for patient information.
It's clear banning them isn't the whole solution if staff rely on instant messaging. What's the need for secure alternatives, and what should they offer?
You're right, prohibition isn't viable when, reportedly, 43% of NHS staff use instant messaging for work. The imperative is to provide compliant apps designed specifically for the health sector. Robust examples like Forward or Silo show what's needed. They offer familiar functions, messaging, file sharing, but integrate essential healthcare features.
What specifically?
Accessible staff directories to find colleagues quickly, secure access to patient profiles, real-time updates within a controlled, audited environment. Clinicians aren't forced to carry bits of paper or use insecure channels. They can share time-sensitive info efficiently and securely. It addresses the practical need while upholding legal and ethical obligations.
And how robust is the security on these compliant apps? Does it really meet the standard needed, like banking apps?
Absolutely. The protocols must mirror, sometimes even exceed, banking security, a much higher level of protection than consumer apps. Data encrypted robustly, both on the phone and server, with origin tracking for audit trails. Secure username, password, or PIN required for login, with automatic reentry after inactivity. Critically, patient data prevented from storing in the native gallery. Notifications hidden by default to prevent accidental viewing on locked screens. These measures protect data at every touchpoint, aligning fully with GDPR and professional obligations.
Moving from digital platforms, let's talk about improving written communication itself, referral and discharge letters. Any practical recommendations or best practices?
A strongly supported recommendation is the widespread use of structured referral and reply discharge letters. Research consistently shows they improve comprehension, can reduce letter length, and GPs generally prefer them. This can be hugely facilitated by Health IT, using structured fields and EHRs rather than just free text. Computer-generated letters further enhance clarity and completeness, a big step away from current inconsistencies.
Structured letters sound like a clear improvement. Any potential pitfalls or unintended consequences we should be aware of?
It's vital to acknowledge potential downsides. While beneficial, structured letters can sometimes mean more initial workload if forms are too long or complex. There's also a caution against overuse of urgent referral tick boxes. If everything's urgent, nothing is. Studies show it often doesn't get patients seen earlier anyway, so implementation needs careful thought and refinement.
Beyond letter format, what about changing the underlying communication processes? What interventions are most effective for driving real change?
Multifaceted, broad interventions consistently prove more effective than narrow ones. A holistic approach combining clear guidelines, ongoing training, and the structured forms we discussed. This embeds better practices into daily workflow. For example, computer-generated discharge summaries significantly reduce omitted essential items, improving safety. Computerized referral systems could reduce GP admin work and enable more timely communication between primary and secondary care. It's about changing the system, not just fixing outputs.
And the issue of timeliness, especially for discharge summaries. Any practical solutions to get letters there sooner?
Timeliness is paramount. One practical suggestion is simply giving copies, or the original letter, directly to the patient on discharge.
Handing it straight to the patient.
Yes. It can ensure the information reaches the GP much sooner than relying on post or potentially delayed electronic transfers. There's also the open notes concept, sharing notes directly with patients. This increases engagement and makes them partners in care. Though there are nuances potential for specialists to omit sensitive info to avoid patient distress. So, transparency is valuable, but needs careful management, balancing access with well-being.
This brings us to broader records management principles. The NHS Records Management Code of Practice 2021 provides a framework. How extensive is its scope?
It's exceptionally comprehensive. It's the definitive guide for records management across NHS organizations, adult social care, and private providers working for the NHS in England. And it applies to all record formats: paper, digital, images, audio, video, emails, SMS, social media content. The goal is consistent, secure, effective management, guiding everything from legal obligations to secure disposal. An indispensable roadmap.
And what key legal obligations underpin this code and govern how records are managed in the UK? It sounds complex.
It is multi-layered. The Public Records Act 1958 and Local Government Act 1972 mandate proper safekeeping and disposal of public records, including NHS records. The Freedom of Information Act 2000, FOIA, governs access to non-personal public records and stresses good records management for transparency. Then, UK GDPR and the Data Protection Act 2018 are principal for personal data, requiring data protection impact assessments, DPIAs, for new or high-risk processing, enforcing accountability. And the Health and Social Care Act 2008, Regulation 17, requires secure maintenance of accurate, complete records for patients, staff, management regulated by the CQC, a comprehensive legal framework demanding adherence.
Beyond legal requirements, what about professional obligations, ethical principles?
Absolutely. Significant professional responsibilities exist. Central are the 8 Caldecott principles, focusing on confidentiality and appropriate data sharing, guiding ethical use only when necessary. Furthermore, professional bodies Academy of Medical Royal Colleges, GMC, RCN, set explicit record-keeping standards members must comply with, guiding content, storage, access, management throughout the life cycle, reinforcing meticulous ethical record management as a core duty.
So given these obligations, how does the code guide practical design and implementation of record-keeping systems? It covers the whole record journey.
Precisely. The code emphasizes systems covering the entire record's lifecycle, from creation capturing accurate info initially, through using it in practice, retention according to schedules, then appraisal determining historical research value for potential preservation, and finally, secure disposal if not preserved. This whole process is guided by standards like ISO 15489-1.2016, focusing on business principles for effective records management, ensuring a structured approach.
And what about authenticity and data integrity? How does the code address these vital characteristics?
They're absolutely critical. The code details that a valid record must be authentic, is what it claims, by who it claims, when it claims, reliable, content trustworthy, integral, complete, unaltered, and usable, can be found, retrieved, interpreted. Context is established by linking related records, and DPIAs are stressed as essential.
Data protection impact assessments.
Yes, crucial for proactively identifying and mitigating privacy risks, especially with new systems like offsite storage or cloud solutions. Conducted before new high-risk processing, ensuring risks are addressed upfront, providing evidence of due diligence.
Let's move into the legal and ethical landscape, a fundamental question. Who actually owns patient records in the UK, and what rights do patients have to access them?
A common point of confusion. In the UK, NHS medical records generally belong to the Secretary of State for Health. The physical storage might belong to the provider, but the information itself is held on behalf of the state. However, this doesn't diminish patient rights. Under Data Protection Acts and FOIA, patients have robust rights to get a copy, check for errors, insist factual inaccuracies are amended, though limited exceptions apply breaching third-party confidentiality or if disclosure would harm the patient's well-being, like some psychiatric assessments.
So generally, who can view a patient's record? And are there specific situations where access rules might be overridden?
Generally, access is restricted. Typically, only the patient and healthcare providers directly involved in their immediate care. This maintains confidentiality within the team. Patients can, of course, consent for others to access. Overriding rules happens in specific, legally defined situations. Lack of capacity, comatose patients, minors, unless emancipated. Incapacitating psychiatric illness, a legal guardian accesses to make decisions in their best interest. In a medical emergency with a non-communicative patient, consent is generally implied, unless an advance directive states otherwise. For legitimate research, audit, evaluation, access is allowed, but strictly without identifying information to protect privacy. And critically, risk of death or serious harm. Information can be shared with authorities without explicit permission if failure to do so would result in death or harm to the patient or others. But this info can't then be used to initiate charges unless those grave criteria are met. A careful balance.
Beyond individual access, what about overarching data security requirements?
Yeah.
And how often do medical data breaches actually happen? It sounds like a major concern.
The law mandates robust safeguards, especially with electronic sharing. Jurisdictions like the US and EU have mandatory breach notifications. But privacy extends beyond legislation. Professional secrecy applies broadly. Practitioners, psychologists, nurses, physios, admin staff. Confidentiality must be maintained everywhere. Consultations, informing relatives, corridor chats, phone calls, ward boards. Yet breaches are a significant ongoing problem. Statistics are alarming. Between 2006 and 2012 alone, 767 breaches compromised over 23.6 million patients' confidential health info. Securing the sensitive data is an immense, evolving challenge.
Those numbers are truly alarming. Are there specific examples of deliberate abuses of medical records beyond accidental breaches?
Unfortunately, yes. Concerning examples exist. Confidentiality violations when transcription storage is outsourced, allowing unaccountable access. A significant security gap. Falsification. Intentional falsification by a medical professional is a serious felony in most U.S. jurisdictions due to implications for care, diagnosis, legal processes. Historically, intentional falsification or concealment in records of intersex individuals to hide birth sex has occurred, raising profound ethical concerns. We've even seen governments refuse disclosure of records for military personnel used as experimental subjects, highlighting power imbalances impacting transparency. These cases underscore the need for strict oversight and unwavering ethics.
A sobering reminder. Finally records retention and disposal under the NHS Code. What are the principles and the challenges with digital records?
The code provides detailed minimum retention periods. Once reached, records can typically be disposed of securely, unless selected for permanent preservation due to historical research value. Digital records present unique challenges. Unlike paper's visible degradation, digital media suffers bit rot demagnetization, altering information, compromising authenticity over time. Software upgrades make older applications unusable, rendering old records inaccessible. Digital continuity requires constant effort migration to new formats to ensure authenticity and usability over decades, a significant resource challenge.
And when destroying records, what are the secure methods for paper and digital?
For paper, secure destruction is vital. In-house secure shredding or approved off-site companies. Never domestic waste or rubbish tips. Confidential material remains accessible. Formal destruction certificates linked to specific records are essential for audit trails. Digital destruction is harder. Simple deletion often doesn't meet ISO 27001 standards for permanent destruction. Info is recoverable. Ideally, systems allow true, irreversible deletion. If not feasible, records marked dormant archived with an audit trail removed from active use. The aim is irreversible destruction where appropriate and legal.
Are there times when, regardless of retention period, records cannot be destroyed?
Absolutely. Critical situations mandate retention. If subject to an active access request, subject access request, FOIA request, cannot destroy until resolved. If required for notified legal proceedings, court order, impending case, coroner's inquest. If of interest to a public inquiry, e.g. child sexual abuse inquiry, infected blood inquiry, COVID-19 inquiry, must retain until explicit guidance issued. These legal holds override standard schedules.
Can you give examples of how varied retention periods are in the NHS code? It sounds complex.
It is very granular, reflecting diverse needs. Dental records, 15 years. GP records, deceased, 10 years post-death, medico-legal. Then review for research value. GP records, deregistered, reason unknown. Currently 100 years under review. Obstetrics maternity, 25 years, part of child's record. Cancer oncology, 30 years from diagnosis or 8 years post-death. Long-term recurring illness, 20 years or 10 years post-death. SARC records, 30 years or 10 years post-death. Medico-legal. Clinical audit, 5 years from audit year. Clinical diaries, 2 years if transcribed, 8 years otherwise. Referrals not accepted, 2 years from rejection. Telephony records, 1 year minimum NHS contract. This range shows the complexity.
Most records eventually get disposed of, but what about the few kept permanently? How are they selected, especially sensitive patient records?
The Public Records Act mandates selecting a small core, typically 265% for permanent preservation due to enduring historical or research value. Transferred to a place of deposit, usually a public archive. For patient records, criteria are incredibly strict due to sensitivity. Only considered if unusually long complete runs, relate to unique local factors, support research into rare long-term conditions, relate to significant events, document new treatments, or shed light on organizational functioning failure. It requires thorough consultation. Clinicians, records management, Caldecott Guardian. Patient consent may be needed unless legally mandated. Anonymization is key, where identity isn't essential for research value, protecting privacy while preserving insight.
Professor, we've covered a vast amount today, from the daily grind of documentation to profound legal and ethical implications. As we conclude, what are your final thoughts?
My final thought is this. Healthcare information management is constantly evolving. The challenges of documentation and communication are persistent. But, as we've discussed, there is incredible potential in technology, like AI, to automate tasks and free up clinicians for the human element. Yet, tech is just one piece. It underscores the vital need for adaptability, critical thinking, a proactive approach to innovation, all while steadfastly upholding ethical and legal obligations with patient data. True value lies not just in collecting data, but ensuring it's accurate, accessible, secure, and used effectively to enhance patient care and support clinician well-being. It requires a cultural shift, embedding best practices everywhere.
We trust this deep dive on Deep Dive Ortho has provided you with valuable practical insights into navigating healthcare documentation and communication. If you found this discussion helpful, please consider rating and sharing Deep Dive Ortho with your colleagues. It really does help us reach more professionals like you. Thank you, Professor, for your invaluable insights today. And thank you, our listener, for joining us on this deep dive. Until next time, keep exploring and keep learning.